Welcome to my talk on dermatological presentations in darker skin types. My name is Ikra Ashraf and I am a dermatology registrar in the UK. I am also the DermReg on Instagram. I recently delivered this talk in conjunction with Manchester RheumSoc, Manchester DermSoc and Manchester BAME Medical Society, who invited me to speak on this important and topical subject. Hopefully my presentation will be useful and will also provide some food for thought. Before launching into the talk, I just want to mention that dermatological presentations in darker skin types is a very large and broad topic, and it's beyond the scope of this presentation to cover all areas. Therefore, I will be focusing on areas that I feel are most relevant to you all as medical students and as junior doctors. I will begin by talking about why dermatological presentations in darker skin types is an important subject, how we define skin of colour, recognising clinical signs in darker skin types, then moving on to common skin presentations in darker skin types, skin cancer, emergency presentations, and finally summarising this. There is also a quiz which will be available at the end of this presentation, and the answers of this are available on my Instagram page. As we are all aware, the COVID-19 pandemic has highlighted quite significant health inequalities that exist within the Black, Asian and minority ethnic community. Data recorded and analysed by NHS England has shown that within the Indian population, there is a death rate 1.5 times higher than expected. Within the Pakistani population, the death rate is 2.8 times higher than expected. And within the Afro-Caribbean population, the observed death rate is 4.3 times higher than expected. Now, there are many different factors that play into health inequalities. These include both cultural and social factors. So, for example, socioeconomic background, cultural factors such as language barriers, different health-seeking behaviours, cultural beliefs and practices. There are also misconceptions that exist. Of relevance to dermatology, darker-skinned individuals may think that they don't need to use sunscreen to protect their skin due to having a higher melanin content in their skin, but in fact darker skin only has an average SPF of 13.4, which is marginally higher than lighter skin, which has an average SPF of 3.4, so sunscreen is needed for both light and dark-skinned individuals. It's important for us to understand all the different factors that feed into these health inequalities in order to be able to better understand them. Now focusing on health inequalities in dermatology. A study published in 2006 found that there is a 2 to 3-fold risk for mortality amongst Black patients with melanoma as compared to their white counterparts. What makes this statistic even more shocking is that studies have shown that Black-skinned individuals are at a 20 to 30-fold reduced risk of getting skin cancer as compared to their white-skinned counterparts. A study published in 2016 reported that a serious disparity exists in melanoma diagnosis and outcome for patients compared with minorities. This hides one of the largest disparities in survival for any cancer. Moving away from skin cancer, there is anecdotal evidence and there are also studies to suggest that darker-skinned individuals with skin problems may be diagnosed later or undertreated. A study evaluating Lyme disease in patients with skin of colour showed that there was a failure to recognise the early disease through the classical rash of erythema chronicum migrans. Instead, patients were diagnosed at the later arthritic stages, resulting in greater morbidity and mortality. Looking at eczema, which is a much more common skin presentation, a study found that reliance on erythema scores may mask severe atopic eczema in Black children compared to their white counterparts, and in turn this may lead to undertreatment of their skin condition. There have been multiple articles published in the media looking at the lack of training and awareness of skin conditions in skin of colour. This slide just highlights a couple of articles that I've come across. So an article from The Guardian on the bottom left, Decolonizing Dermatology, Why Black and Brown Skin Need Better Treatment. And this is actually an article written by a GP who comments on his experiences of training and how he didn't feel confident with diagnosing skin conditions in skin of colour. On the right, there is an article published in the New York Times, which again highlights the diversity gap embedded in medical training. For all the reasons highlighted and discussed, it's important that we can recognise skin presentations in darker skin types and that these are not missed. Lack of education leads to misdiagnosis and delays in diagnosis, which ultimately leads to poor patient outcomes. As well as having an impact on morbidity and mortality, it's also important to note that skin disease also impacts on quality of life and on psychological well-being due to its visual nature. What is the definition of skin of colour? The term skin of colour isn't very well defined, but we often use it to describe individuals who have Fitzpatrick type 4 to 6 skin. I've highlighted this on the Fitzpatrick scale using a red box. It's important to note that the Fitzpatrick type of an individual is independent of their ethnicity and their racial origin. We will now cover some common clinical signs. For the purposes of these slides, I have used illustrations of lighter skinned individuals on the left for the most part and darker skinned individuals on the right. As you can see from this slide, the redness is much more easy to appreciate on lighter skinned individuals. The photo of the light skinned limb with the targetwood rash is the classical erythema chronicum migrans rash that is seen with Lyme disease. Adjacent to this on the left is the same rash shown in a darker skinned individual. As you can see, it appears differently as there is less erythema and the outer ring of erythema is also missing. Therefore, it may be missed and there may be a delay in diagnosis, leading to further complications as discussed earlier. The photo on the top right demonstrates eyelid erythema. This photo actually shows the classical pinky purple heliotrope rash that is seen with dermatomyositis. And again, you can see that it is very subtle and may easily be missed if this isn't something that you are looking for. This slide demonstrates both pallor of the hands and conjunctival pallor in lighter skinned and darker skinned individuals. As you can see with the pallor of the hands, in lighter skinned individuals, this may be more easy to appreciate due to the lack of erythema. However, in darker skinned individuals, who often do not have as much erythema, in normal circumstances, paleness may be less noticeable and therefore missed. It is important to be aware of this and to make sure that you look for this carefully. Similarly, jaundice is a sign that may be easily missed in patients with skin of colour, as it is less evident in the skin, and often it is the sclera which would be the giveaway sign in darker skinned individuals. Now moving on to common skin presentations. This slide shows atopic dermatitis or eczema in both lighter and darker skinned individuals. On the left, you can see the classical erythematous eczematous rash in the flexures behind the knees, and also the same rash is shown on the anterior aspect of the knees. There's also evidence of excoriations, and it's very easy to appreciate the erythema or redness at the affected sites. This is in contrast to eczema in patients with skin of colour. So on the right-hand side of the slide, you can see that in darker skin, the erythema is much less obvious. Instead, you see this dry, scaly, and in some places hyperpigmented rash. For this reason, as I mentioned earlier, erythema alone should not be used as a marker of eczema activity, as in darker skinned individuals, this may result in eczema being undertreated. If eczema isn't adequately treated, then this can result in thickening of the skin at affected sites, a phenomenon known as lichenification. This is where the skin becomes thicker, rough, and almost bark-like. These areas are very itchy and make it difficult to break the itch-scratch cycle and hence control the disease. It is also important to note that repeated inflammation of the skin due to skin conditions such as eczema can result in pigment changes over time, especially if the eczema is very severe or if it hasn't been controlled for a long time. The skin at affected sites may become darker or hyperpigmented as compared to the surrounding normal skin, or alternatively, it may become lighter or hypopigmented in contrast to surrounding normal skin. Patients may refer to this as scarring, and although it is often not permanent, it can be disfiguring for patients and may take many years for the colour in the affected sites to return and normalise. Looking at the photo of a young child's face on the middle of this slide, you can see that this is a young child with skin of colour, and they have a lighter patch of skin around their mouth and over the nose area. This is something that may in fact be confused with a condition known as vitiligo, where there is destruction of the melanocytes which produce the skin pigmentation. However, this condition is pityriasis alba, which is effectively subclinical eczema. In contrast to vitiligo, the lighter skin is hypopigmented, so lighter than the surrounding skin, rather than depigmented, where there is complete loss of colour of the skin. Also, individuals with pityriasis alba will often have a family or a personal history of atopy, so eczema, hay fever, or asthma. And the colour in the affected skin will normalise with usual eczema treatments, including a moisturising cream, a mild topical steroid, and also use of a soap substitute. Pityriasis alba can also occur in lighter skinned individuals, but it is often less prominent due to the less striking contrast between normal and affected skin. In order to reduce prominence or prevent development of the skin, sunscreen can also be applied to the face in order to minimize tanning from the sun, which might emphasize the contrast between the normal skin and the subclinical eczema. The photo below this shows hyperpigmentation on both sides of the neck and quite chronic changes. There may also be thickening of the skin, which we discussed earlier, but it is difficult to tell from the photo alone. You would want to have a closer look at the skin and also feel the affected sites. This slide shows psoriasis in both lighter and darker skin types. On the left, you can see the classical salmon pink plaques with scale that are described in dermatology textbooks. However, in contrast, on the right-hand side, you can see that psoriasis can look somewhat different in darker skin. The photo on the top right shows psoriasis in a patient of colour, and you can appreciate that there is almost a purple hue to the psoriasis rather than the salmon pink colour that is seen in lighter skinned individuals. As with eczema, if the affected sites are undertreated, this can result in pigmentary changes, which are often more evident in patients with skin of colour. Psoriasis may present in a number of ways, and the most classical presentation is that of chronic plaque psoriasis, where patients have large scaly plaques affecting the extensor surfaces, so over the back of the elbows, over the anterior aspects of the knees. Other variations of psoriasis are guttate psoriasis, which is somewhat like the picture shown in the middle of this slide, where patients have small, red, scaly, teardrop-shaped areas of psoriasis. And this is more common in children and young adults, especially after a streptococcal throat infection. Other types of psoriasis include inverse psoriasis, which is a form of psoriasis that tends to affect the skin folds. This is not pictured on this slide. This slide shows acne in both lighter skinned individuals and in individuals with skin of colour. On the left-hand side, you can see that there are papules and pustules on the facial skin with surrounding erythema. However, in darker skinned individuals, the erythema is much more subtle and may not be as evident. The same active acne skin lesions are seen in the darker skinned patients here. However, you can also appreciate that there are areas of darkened skin or post-inflammatory hyperpigmentation. This is a complication of acne, which patients with skin of colour are much more prone to. It can be very disfiguring and distressing for patients, as once their active acne has cleared, they are left with an uneven skin tone. For this reason, it is important to always treat acne in a stepwise way and escalate treatment appropriately, as preventing post-inflammatory hyperpigmentation by treatment of the acne is much easier than managing post-inflammatory hyperpigmentation. Here we can see cellulitis in both lighter skinned individuals on the left and in darker skinned individuals on the right. Erythema, which is often the hallmark of cellulitis along with other signs such as warmth, tenderness, and swelling, is much more easy to appreciate in the lighter skinned individuals. In the photos of patients with skin of colour, you can see that the erythema is much more subtle, therefore closer inspection of the skin is required, and it is important to ensure that you have good lighting. Good lighting is key to ensuring that signs are not missed. Here we can see pityriasis versicolor, which is a common yeast infection in both lighter skinned and darker skinned types. This condition results in scaly discoloured patches, which most commonly affect the trunk and the back area. Patients show areas of hypopigmentation. So as I mentioned earlier, the affected skin is lighter when compared to the surrounding skin. And just to reiterate that this is in contrast to depigmentation, where there is complete loss of colour or pigment in vitiligo. As you can see from these photos, this condition may be more easy to spot in patients with skin of colour. due to the more visible contrast between the normal skin and the affected skin. This slide shows bullous pemphigoid, which is a blistering skin condition in both individuals with lighter skin and in individuals with darker skin types. Bullous pemphigoid starts as a erythematous, itchy, urticated rash, and this precedes the development of blisters. As we have discussed with other skin conditions, erythema may be less easy to appreciate and therefore missed in darker skin types. This means that in bullous pemphigoid, the preceding itchy, red, urticated rash may not be recognized as the preceding rash for bullous pemphigoid. Again, in these photos, you can see that in the lighter skinned patients, the erythema around the blisters is much more easy to see. However, for the patients with skin of colour, the erythema is much more subtle and may be missed if there isn't adequate lighting or if you are not looking closely enough. This slide shows vitiligo in both patients with skin of colour on the right and in patients with lighter skin on the left. As you can see, there is a much more striking contrast between the normal skin and the affected skin in patients of colour. In patients with lighter skin, it may be more easy to camouflage and mask the affected sites. However, as you can imagine, in darker skinned individuals, this is much more difficult. The greater visibility of this skin disease can cause considerable distress and can also have a greater psychological impact on patients with darker skin types. It is important to be aware of this and appreciate this when managing this condition. Now moving on to skin cancers. Skin cancers do occur in patients with skin of colour, but they are much more rare. This slide shows basal cell carcinomas. This is the most common type of skin cancer seen in white-skinned individuals. The photos on the left show a series of typical basal cell carcinomas, which consists of a pearly, skin-coloured lesion with a rolled edge and telangiectasia. The BCCs can ulcerate and often present as a non-healing spot on sun-exposed sites. Patients with skin of colour can also develop basal cell carcinomas, and they are more likely to develop what we call pigmented basal cell carcinomas. So on the right in the photos you can see pigmented basal cell carcinomas, which are pearly brown or black coloured lesions. These can be more challenging to diagnose, and other differentials may be considered. Pigmented basal cell carcinomas can occur in white or darker skinned individuals, but more than 50% of basal cell carcinomas found in patients with skin of colour are pigmented. This slide shows a selection of squamous cell carcinomas in both lighter and darker skin types. Squamous cell carcinoma is the most common type of skin cancer in patients with skin of colour. It may present in a number of different ways. For example, it may present as a red-brown patch on the skin with a rough, scaly, crusted surface which ulcerates and is tender. They may also present as small dome or crater-shaped lesions which rapidly increase in size. The photo in the middle of this slide shows an example of such a lesion, which is known as a keratoacanthoma. Keratoacanthomas are considered to be on the same spectrum as squamous cell carcinomas and are treated in the same way. With skin cancers, the history is key, and this, along with clinical assessment of the lesion, will help guide diagnosis and management. This slide shows the varying presentations of melanoma in different skin types. The ABCDE rule of skin cancer can be helpful in identifying melanoma. A stands for asymmetry. The two halves of the skin lesion may differ in shape. B is for border. The edges of the skin lesion may be irregular or blurred and sometimes show notches. C is for colour. There may be variation in colour with different shades of brown, pink and black seen within the same lesion. D is for diameter. Most melanomas are at least 6 millimeters in diameter, and any growing lesion may indicate suspicion of a skin cancer. E stands for expert advice, so if in doubt, it is important to signpost the patient to their GP or to a dermatologist. As I mentioned earlier in this talk, there is a 20 to 30-fold lower incidence of melanoma in darker skin types, but melanoma in darker skin types is associated with a greater mortality due to later detection and diagnosis. Melanoma in darker skin types is more common on acral sites, so the palms and soles, as demonstrated by the photos on the bottom row in the middle and on the right. Other less sun-exposed sites may also be more common sites for melanoma in darker skinned individuals. These include around the nail, under the nail, around the anus and in the genital area. The photos shown here on the left in the lighter skinned individuals and the one on the top right all show features of the ABCDE rule that I mentioned. The photo in the top middle left shows a pink-red nodular growth on the skin with some surrounding erythema. This lesion is in fact a melanoma, but it is a type of melanoma known as an amelanotic melanoma. The term amelanotic melanoma is used to describe melanoma lesions that are partially or completely devoid of any pigment. Truly amelanotic melanomas are very rare. Moving on to more urgent presentations, this slide shows urticaria and angioedema in lighter and darker skin types. On the left, on the lighter skinned individuals, you can appreciate erythematous, urticated or raised patches of skin. However, on the right, on patients with skin of colour, erythema is not seen, and instead the urticated, raised patches appear to be paler than the surrounding skin. On this slide, I have also included images of angioedema, which is swelling of the lower layer of the skin and tissue just underneath the skin and mucous membranes. This may often be associated with the urticarial rash seen on the skin. This slide shows a purpuric rash in both lighter skinned and darker skinned patients. Purpura is a purple, pink, palpable rash which is non-blanching. It can be associated with many different conditions, including acute meningococcemia, septicemia from other systemic infections, drugs, and may also be seen in autoimmune conditions. The photos of the purpuric rash on the lighter skinned patients on the left shows an obvious purple-pink rash, which could easily be spotted even in poor lighting. However, on looking at the photos of the patients with skin of colour on the right, you can see that the purpuric rash is much less evident in darker skin and could easily be missed if not looking carefully and with appropriate lighting. This could have devastating consequences for the patient, especially if the cause of their rash is septicemia or an acute meningococcemia. Here we can see erythroderma in both lighter and darker skinned individuals. Erythroderma is a term used to describe widespread reddening of the skin, involving more than 90% of the body surface area. This can be due to a number of different conditions. Most commonly, patients will have underlying skin conditions such as eczema or psoriasis. Other causes can include drugs and cutaneous lymphoma. From looking at the photos on this slide, you will see that in patients with lighter skin, the redness is much more easy to appreciate. However, as seen in the photos on the right side of this slide, full body redness is not a prominent feature in patients with skin of colour. Instead, patients may have other signs of chronic skin disease, such as hyperpigmentation, and there may be evidence of peeling or scaling of the skin, known as exfoliative dermatitis. Restoration of the impaired skin barrier is important in these patients. This is done through the use of thick, greasy emollients topically, such as 50-50 white soft paraffin, liquid paraffin, and also through hydration of the patient orally or through IV fluids. In addition, topical steroids may be beneficial in settling the inflammation and controlling the skin disease. This slide shows eczema hepaticum in patients of varying skin types. Eczema hepaticum is characterized by monomorphic, punched-out areas of the skin. Initially, small vesicles are seen at the site of infection. As the vesicles dry up, or if they are excoriated, they leave erosions, which may become infected with a secondary bacterial infection. Eczema is most commonly seen in infants and children with eczema or atopic dermatitis. If there are breaks in the skin from excoriating or trauma, then the skin may become infected with the herpes simplex virus, leading to this presentation of eczema hepaticum. Patients may be systemically unwell with a fever, and it is important to take both bacterial and viral swabs of the lesions and to start correct treatment, which would be acyclovir and also flucloxacillin if there is suspicion of secondary bacterial infection. From looking at the photos on this slide, you will appreciate that erythema is less prominent in patients with skin of colour, and this is a recurrent theme with skin disease in patients with skin of colour. You may recognise the photos on this slide from social media campaigns calling for better representation of skin of colour in dermatology textbooks and resources. A Kawasaki-like syndrome has been linked to COVID. Kawasaki disease is a systemic vasculitis which mainly affects children under the age of 5 years. Children with this condition have a very high temperature, which is associated with a number of other features. From a skin perspective, children may develop a measles-like rash, which is seen on the left in the photo of the lighter skinned child. However, from looking at the photo of the child with skin of colour on the right, you will see that the rash appears somewhat different in darker skin and may be missed. Especially from looking at the smaller photos in the middle of the slide, you will see that the signs on darker skin are much more subtle. Interestingly, there is evidence and literature to suggest that artificial intelligence also struggles to detect skin disease in skin of colour. This is important to be aware of, as artificial has an emerging and ever-increasing role in detecting skin disease and skin cancer. Further development is needed to the artificial intelligence software that is used before it can be relied upon as a robust tool for diagnosis. Here we can see Stevens-Johnson syndrome and toxic epidermal necrolysis in both lighter skinned and darker skinned patients. Stevens-Johnson syndrome and toxic epidermal necrolysis are considered to be on a spectrum depending on the body surface area involved. The photos on this slide are quite striking, and you will see that there is quite extensive mucosal involvement in both the lighter skinned patient on the left and the darker skinned patient on the top right. In the photos on the middle, you will see that there is quite extensive involvement of the skin with peeling and erythema. Earlier signs of both Stevens-Johnson syndrome and toxic epidermal necrolysis may be trickier to spot, as erythema may be less visible in darker skinned patients. These patients are usually systemically unwell and require input from the intensive care unit and burns unit in their management. In summary, by going through these cases, I've hopefully reinforced the idea that skin conditions can present differently in patients with skin of colour. Most importantly, erythema may be absent or more subtle in skin conditions in darker skin types. Therefore, it is important to have good lighting to ensure that subtle signs are not missed. In addition to this, certain skin presentations and complications are much more prevalent in darker skin types. Pigmentary changes such as hyperpigmentation, which may occur after any inflammatory disease, such as eczema or psoriasis, is more common in patients with skin of colour. Similarly, post-inflammatory hyperpigmentation after acne is much more common in darker skin types. In addition, pigmentary problems such as melasma, in which adults, most commonly females, develop brown or greyish patches of pigmentation on their face, is also more commonly seen in Asian and Afro-Caribbean skin types. Keloid scars are also more common in darker skin types, therefore it is important to warn and inform patients with skin of colour of these risks when they are consented for any surgical procedure or treatment which causes trauma to the skin. Patients with skin of colour are also more likely to use skin lightening and bleaching treatments, which come along with many side effects. It is important to be mindful of these when assessing patients with skin of colour. Certain skin and hair disorders are also more common in darker skinned individuals, and this isn't something that I have discussed in this talk, but follicular disorders affecting the scalp and beard are more common in Afro-Caribbean individuals due to the structure of the hair. In addition, hair practices, including weaves or hairstyles which pull on the hair tightly, may result in traction alopecia. As we have discussed, acral skin cancers and skin cancers in less sun-exposed sites are more common in patients with skin of colour. It is important to be aware of the psychological impacts of skin disease, and certain skin presentations are more distressing for patients with darker skin. For example, as we discussed earlier, Vitiligo is much more striking in patients with skin of colour and therefore more likely to have a bigger impact on psychological well-being. Similarly, post-inflammatory hyperpigmentation after acne is more prevalent in patients with darker skin types and can have a profound psychological impact on patients even after their active acne has been treated and has cleared. Finally, it is important to be vigilant and to be aware that all skin types can get skin cancer, and patients with all skin types should use sun protection. Thank you for listening. I hope that this talk has provided an insight into recognizing dermatological presentations in darker skin types. Here I have highlighted some useful resources for you to further enhance your knowledge in this subject matter. Brown Skin Matters is an Instagram page set up by a non-medic mum who noticed a rash on her son who has skin of colour. She attempted to perform a Google search to identify the rash, but found that all the pictures that she came across were of patients with white skin. Therefore, she set up this Instagram page as a resource for darker skinned patients and to raise awareness of the lack of representation of darker skinned individuals. Team Education is an Instagram page set up by 2 junior doctors that aims to promote diverse representation in medical education, and again they have useful photos and posts of different dermatological conditions in patients of skin of colour. I would also like to highlight the DermNet New Zealand website, which is listed at the bottom. They have a fantastic collection of photos of many different skin conditions and have been working on increasing representation of darker skinned patients in their library. Quite a few of the photos used in this presentation have been taken from the DermNet NZ website. Finally, I have included a quiz going over some of the conditions that we have talked about and a few other important conditions. The answers to this quiz are available on my Instagram page, the DermReg. If you found this talk useful, I would be grateful if you would like, comment and subscribe. Please comment below any other topic areas that you would like me to cover, or if you have any questions leading on from this talk.